Thank you for being here. We're very excited to talk to you today about the topic of health equity and emergency medicine. And our group is the IDEAL at UCLA, International and Domestic Health Equity and Leadership. Our team members for this talk is Dr. Shamshar Samra, who couldn't be with us unfortunately today. I am Mohsen Saidinejad at Harbor UCLA. Dr. Breena Taira, who is actually the chair of our section of IDEAL at UCLA. Kian Preston-Suni, who's one of our administrative fellows, and Hsieh, who is Director of Population Health for the Department of Health Services at UCLA, at County of Los Angeles. So the main objective of this talk is to share with you the working model for building a section of health equity in an academic emergency medicine program, and to talk to you a little bit about what we have done at UCLA and to share that with you guys. We have no disclosures. So why do we care about health equity and why is it so important? I think this diagram shows it pretty well, that of all of the factors and all the determinants of health, the one that has the greatest influence and contribution is the social and economic factors. As you can see, those factors alone account for 40% of all of the determinants of health, which means that is greater than health behaviors, and it's greater than genes, physical environment, and clinical care all put together. So therefore, it's a very important component that is not really being addressed as well in general.
Okay, good afternoon, everyone. So I'm going to start with a little bit of background. So in 2008, Michael Marmot and the WHO Commission on the Social Determinants of Health declared that social injustice is killing people on a grand scale. They released a report called Closing a Gap in a Generation, which was a call to healthcare providers and institutions worldwide to recognize the connection between social injustice and poor health outcomes, and to call on us all to act. So they declared within their report that the poor health of the poor is really caused by the unequal distribution of power, income, goods, and services, and that in order to improve population health, that we as a society need to start to begin to address structural inequities. And so who within the United States healthcare system really understands the way that health inequity impacts our communities? That would clearly be the emergency physicians and the staff of the emergency departments. We are the only social service that is by law open to everyone, and also by nature open 24/7. And so we care for the most marginalized of society when others won't. And in doing so, we're really the ones that bear witness to how inequity impacts population health, and specifically within our own communities. So we're all familiar with the saying that of Virchow that's become very famous, that the physician is the natural attorney for the poor. So I would argue that if Virchow were alive today, that he would actually modify that statement to be the emergency physician is the natural attorney for the poor. And that is really why health equity and emergency medicine are the perfect fit. So to begin to advocate for health equity and to eliminate health disparities, from the standpoint of emergency medicine, we need to start to make this connection between the biopsychosocial roots, the biopsychosocial model of health, and the emergency department. So we all understand this as emergency physicians intuitively, right? Because when you add homelessness and schizophrenia to diabetes, we know that that adds layers of complexity that portend poor health outcomes. And so we need to begin to understand and to articulate that emergency department visits too are rooted not only in the biomedical, but can also be rooted in the social and the psychologic, or in any combination of the three. Our training programs in our departments, however, are typically structured more narrowly to focus on the biomedical. And so this is one of the incongruities that our specialty really is going to have to evolve to recognize. So academic emergency medicine does recognize this by addressing health equity in certain aspects of it. So it's pretty typical now within academic departments to have initiatives surrounding social emergency medicine, global health, or diversity, equity, inclusion. However, oftentimes these initiatives are functioning separately, but the common thread between them really is health equity. And so when we're working to eliminate health disparities, we have to stop and ask ourselves, does it really matter on what side of the border the patient and the provider are standing on? You know, to answer that question, consider this. In my emergency department in Los Angeles, one of the foremost things impacting population health is actually the epidemic of violence in the northern triangle of Central America. And so that epidemic of violence, which is outside of the US borders, is having an enormous impact on rates of fear and PTSD within Los Angeles. And so in my practice setting, as I'm sure in many of yours, you know, social emergency medicine and global health often really becomes one and the same. And beyond that, we also now have good evidence that patients have better outcomes and receive higher quality care when the healthcare workforce treating them looks like them and also speaks the same language. And so in uniting kind of all of these types of initiatives, the common thread clearly is health equity. And so to recognize that, we created this section, a section of health equity within our department. And we're calling it a section of health equity specifically to focus on our end goal of trying to promote population-level health equity. So IDEAL stands for International and Domestic Health Equity and Leadership. And the mission of our section is to recognize and to promote ways in which academic emergency medicine can promote health equity and eliminate health disparities locally, nationally, and globally. And so now that I've described some of the background and also a little bit about the focus of our section, what we're going to do is for the rest of the talk to focus on describing the activities of our section so that if any of you in the audience are interested in creating something similar in your own institutions, that you have a model to reference.
So obviously being based in an academic emergency department or in a case across several different academic emergency departments, education and training is a core part of our mission. And so for IDEAL, that's no different. We've thought a lot about medical education because traditionally, as many of you know, or all of you probably have realized, social factors and health equity isn't really included as part of the traditional curriculum. There's a lot of work now going around the country, both trying to look at how social emergency medicine, social medicine, and health equity can be included both in the didactic curriculum as well as in the bedside curriculum. For IDEAL, we've sort of really looked at all the different factors, all the different opportunities we have to integrate this into the curriculum. With medical students, since we're associated with UCLA, we've actually created the first and only social medicine course available for the medical students, a social medicine selective that brings in community partners, physicians and other healthcare providers, and other individuals working in this space on issues such as immigration, public benefits, and the like. And this course has really been well received at the medical school. It's chaired by Dr. Samra and is, like I mentioned previously, the only course in social medicine, and we're now working with our chair, Dr. Hendy, to look at how we can further integrate social medicine into the broader medical school curriculum. In terms of the residents and faculty, this has been a combination of bedside as well as didactic opportunities. Many programs around the country are now looking at opiate use disorder, and our programs are no different. We've integrated a lot of education about opiate use disorder and treatment pathways into our bedside teaching. We've talked about homelessness, social needs screening, and violence intervention. On the didactic side, we've had several all-LA conferences across the 3 emergency medicine residency programs featuring social emergency medicine. And during orientation, we've also had a poverty simulation. Poverty simulation, some of you have probably heard about this, is a 2 to 3 hour exercise that places learners, such as interns and others, in an environment where they have to accomplish activities of daily living as low-income individuals and face the challenges around food, balancing the checkbook, getting the kids to school on time, and facing adversities such as your car breaking down and other things. And I think the real crux of the poverty simulation comes in the debrief that happens after the simulation, where we've gotten very interesting responses from our interns and other providers who've really come to appreciate the daily challenges that our patients face when they come to the emergency department is just one additional burden. In terms of an independent curriculum, we've developed several electives and selectives around social emergency medicine, and we've also created a set of learning modules that feature a number of topics in social emergency medicine that allow individuals to use a series of cases, look at discussion questions, and look at further reading to really explore the topics and either teach themselves and then be able to use this either as a tool in a small group or for bedside teaching during the clinical day. And finally, a number of additional opportunities have also been integrated into education. We have a number of hands-on opportunities, such as asylum clinics at the various facilities, as well as work in Tijuana. Additionally, as Kian and Mo will discuss later, a number of advocacy and research projects. And one last thing to highlight is the idea of fellowship. This is for learners who are interested in doing more work in health equity and social emergency medicine. It's a 2-year fellowship. Focuses on health equity and social EM, and our 2 fellows are pictured here.
Thank you, Dennis. So, advocacy efforts at IDEAL have really arisen naturally from our shared interest in social medicine. Internally, we've been focused on advocating for the social determinants of health and addressing health disparities within our own emergency departments and within our own health systems at large. Within the field of emergency medicine, we've advocated for recognition of the fact that the majority of our patients' health is determined not by what happens in our departments, but rather outside of our doors. Externally, our advocacy has arisen in response to events. So locally, a number of our members were involved in lobbying against the building of a new jail within Los Angeles County, part of a broader community effort which successfully diverted the funds towards mental health resources. On a national level, a number of our members perform medical evaluations for people seeking asylum. Related to these immigration efforts, we also organized within our group submission of comments to the Department of Homeland Security regarding the proposed rule change to change the definition of public charge for purposes of determining eligibility for immigration. The recent passage of California Senate Bill 1152 was met with a great deal of controversy within our specialty in the state of California. The bill requires that all homeless patients be provided with a meal, weather-appropriate clothing, social work consultation, and identification of appropriate housing after discharge. The bill was met with a great deal of concern within our specialty. There was widespread fear that the departments would be inundated with people just seeking a meal or just seeking some clothing. Our current fellow, Hemang Acharya, recently authored an op-ed arguing that in fact this bill provides us with a valuable opportunity to address some of these upstream factors addressing health within our departments. Also, our group has been involved in looking into ways that we can actually bill for some of these services to capture some of the cost associated with their provision. We would be remiss not to mention our colleagues at Stanford and the University of Washington who created the Social Emergency Medicine Journal Club. This group meets virtually monthly, discusses literature of note, and is a place to talk through works in progress of its constituent members.
So research is another important component of the section activities that we have. The importance of research really is that we do know that health disparity is measurable. A lot of times we can actually wrap our head around it. We can also reduce health disparities through good understanding of research findings. Also, in some cases, we might even be able to eliminate it altogether. So what is important about that is also that on a population level, we do know that there is a direct association between health disparity and social disadvantage. So because of that, health equity becomes a very important part of research modifications. So one of the other considerations to make about research is that research should go beyond just trying to describe the problem of health equity and social determinants of health, but rather to focus on questions that help improve outcomes and help reduce health disparities. So at IDEAL, we've looked at different kind of topics that we can look at in terms of research to be able to encompass the entire spectrum. So some of our research is focused on educational advancements and strategic criteria that helps us develop teaching tools for our trainees and for practitioners. We also do a great deal of quality improvement projects. Most of the bulk of our research projects are around implementation science that looks over the concepts of health literacy, language, immigration, social needs screening. We also have a section on technology and innovation. A couple examples. So one of the studies that we recently completed was a single center study at Olive View, one of our hospitals, looking at the utilization of interpreter assistance. And it looked at the fact that of the patients for whom an interpreter was requested, just about 15% of them have anything noted in the electronic record about that request or any documentation of a live interpreter actually having been used. So the intervention basically was to start educating the providers, first of all, about the right for every patient to have access to a native speaker interpreter service, and also the fact that there are services available to basically educate the providers on where to get access to interpreter services, and also include a little bit of a help on the electronic health record, for example, having a little icon show up on the tracking board that says the patient needs a language interpreter. And just with those simple kind of advancements that were done in this project, they were able to double the proportion of patients who actually had the language interpreter documentation in the electronic health record. So that simple intervention was able to double that reporting of language interpreter into the electronic health system. Another study that we're about to launch now looks at tracking our pediatric asthma patients who are discharged from the ER and trying to just basically try to understand when are they using the medications as they're prescribed, because we have tracking on them. And in addition to that, we're screening them before they go to see whether or not they have any social barriers that they identify up front, so we can then match the stated barriers to the missed doses. So for example, if somebody says, I don't have childcare in the evenings, it's very hard for me to give medication in the evening, we can actually check and see, oh, the dose in the evening, for example, was missed. So those are examples of how research can specifically get to areas that we haven't currently been able to get to. Just a list of a selected group of publications. I'm just going to kind of list those here for you. We have plenty of them. We just selected 4 of them here for you. And I have to also mention that all of the research efforts that are done at institution levels cannot really succeed without community partnerships. A lot of health equity issues rise from the community and basically come into our realm, into the emergency department. So without having community participation, it's very difficult to actually conduct research.
Okay. And just quickly, to conclude, I wanted to add a note about sustainability, because this is an issue that comes up. I've been asked several times, how does one sustain a section like this and its activities? So really, you know, what I would say is that sustainability is the same in sustainability for any type of organization. So really to rally your section around a strong mission statement. And then, you know, as Jim Collins says in Good to Great, it's really important to get the right people on the bus. So having colleagues that, you know, you work well with and also that really share your enthusiasm for that mission statement is clearly important. And finally, it also really helps to have the chair of your department who, quote unquote, gets it and is supportive of your work.
Yeah, so just to wrap it all up, so health equity is very important because, as we mentioned, the social and economic factors are the most important contributors to wellness and health. As a result of this, we need to make sure that we are engaging our providers in better understanding of the social and economic factors that affect our patients as they are treated in the emergency department. Also, not only that we need to be able to understand health equity, but we also have to have a plan once we created a section as we described to assess it frequently and also to be able to make it sustainable, because it's always easy to start something, but to make it sustainable, it's an entirely different discipline. So in terms of education, as we mentioned, it is very important to start the earliest of the scientists at the medical student level and to just teach them about health equity and what it involves in order to be able to understand and work with patients who have challenges socioeconomically. And in terms of sustainability, again, you need to have a process where not only everybody is on board, but you have your hospital leadership, and you have everybody who's a provider, regardless of whether they're a medical student, resident, or a faculty, or a nurse, that they all have the same shared mental model about how to take care of patients who are having disparities. In terms of advocacy, just basically raising awareness about social injustice and inequity, and to be able to, again, reach out to all levels of healthcare and make sure that this continues to stay in the forefront. And research, as we mentioned, should go beyond just describing the problem of health equity, but it should include solutions that help improve outcomes. So with that, I want to just thank all of our IDEAL members, the ones who were part of this group and the ones who contributed to this but are not physically here, also to all of our partners that made this possible to create this section. Thanks. Thank you, Kian. Okay, any questions? Yes.
Hi, I wanted to say, oh, thank you. Hi, I just wanted to say thank you so much for this very, very important talk. I'm currently a fourth year going into emergency medicine this upcoming cycle, or I'm applying this upcoming cycle to enter in 2020. And my question for you is, do you have any thoughts on or suggestions regarding good websites for social justice and health equity literature? What are your recommendations for those?
Dennis, you want to take this?
Yeah, so there are a couple of good websites. One, the IDEAL website has a reading list on there. The Siren website has, the Siren Institute at UCSF has a good reading list. And the Levitt Center website, I think, also links to a number of good links. So I think if you start with those three, I think that'll get you a good ways.
And then actually coming soon, about to be announced in the next couple days, the SAEM Social Emergency Medicine and Population Health group is actually going to be publishing a website that'll have a list of relevant literature in the field.
Oh, okay. Thank you.
Thanks for the amazing presentation of what you guys have achieved. It's really sort of mind-boggling. I have a question about Harrison Alter from Highland, sorry. I have a question about maintaining the esprit de corps. You mentioned the journal club, but how else do you keep this group internally cohesive? Do you have a lab meeting once a week, or how do you maintain the esprit de corps? Thanks.
Yeah, Breena, this is probably for you.
So with a lot of administrative organization, mostly done by me, not by actual administrative support. But no, we have, so that's one of the unique things actually about UCLA is that the academic department is over 5 different hospitals. And so we're all located at different sites. And with LA traffic, we don't actually meet in person that often. But we have regular virtual meetings, once a month. And we also have the Journal Club. But we also have kind of subgroups that are working on particular projects, but we always have a monthly check-in amongst all of the faculty to make sure that we're making progress in all of our different initiatives. So, it's a lot of virtual meeting, mostly.
Yeah, we also have different projects that we're constantly working with each other on. Those are separate meetings on their own. We're working on these educational modules, developing a faculty guidebook for all of those. So we do have other meetings as well, but administrative meetings are, as Breena was stating. Any others?
Thanks, guys. Great presentation. I was wondering if you had any specific strategies for residents or fellows who are, going to choose other pathways after they're done with the program to help emergency physicians sort of better distribute our capital and go and work in places that maybe one of the best things they can do is to work in an area that's medically underserved, specifically for emergency medicine. I'm kind of referencing rural emergency departments, and they don't have to be rural, but other places like that. Do you guys have any strategies for how you try and can guide people in those directions if they're not going to be researchers or take on bigger projects?
Yeah, I can start and whoever else wants to join. So you're right, not everybody wants to look at this from the research standpoint of it. Pretty much all of us want to look at it from the advocacy standpoint, so that no matter where you go is going to be valid. And some of the things we put together in the section can actually be duplicated in many different environments. Some of it depends on resources, some of it really has your institutional buy-ins, and again, the proportion of patients that you actually see who have specific needs. So we happen to be working in safety net populations, most of us, so that's kind of why it's natural. But you will start small, and you see what you have, and then you kind of build around it. And it might not exactly look like what we created. It might be a little bit different looking, but it's a good start for you to get a sense of what sort of topics and thoughts to consider. Anybody else wants to add?
I mean, I think this goes to the work that ADIEM and other groups are working on, right? Sort of all about diversity and inclusion. And I think in terms of training a diverse workforce that wants to work in a number of environments, a number of different underserved environments, such as rural environments, is key. And I think, when we're looking for residents across the UCLA sites, we're definitely, I know many other programs are too, are really looking for individuals who have a number of different passions. And I think we as a faculty are looking at how we support that. And really, I think one thing that we've done is really trying to help residents pick their passions and support them, as opposed to saying, oh, the faculty have a number of projects, you have to work on one of these.
I think we're done, right? Thank you so much, everybody. Really appreciate your participation here.